All right, well, welcome to this lecture on the calculations of doses, and this is for chapter 7 and 8. And to be honest with you, the chapters 7, 8, and 9 all kind of blur together in my mind, so what's important is not so much that you keep them separate as understand that chapter 7, 8, and 9 are all about calculating the dose of a drug for a patient. So chapter 7 kind of brings up the initial idea of what is a dose and brings up some terminology. Chapter 8 goes then into really practicing applying patient-specific factors such as their body weight or body surface area or maybe age, things that are going to individualize doses between different patients. And lastly, chapter 9 talks about dosing drugs that aren't expressed by the weight of the drug. These are ones that are oftentimes dose based off of things like international units or units of activity. So, regardless of the variations, all of the three of these chapters, 7, 8, 9, we'll talk about calculating how much of a drug dose to give to a specific patient. So with that, let's start with some basic definitions on this. And certainly, what is the definition of a dose? The dose of a drug is the quantitative amount administered or taken by a patient to produce the intended medicinal effect. All right. Well, that's the amount of drug to do the thing we want it to do. All right. Now, how do you decide how much drug to give somebody? Well, most drugs, the dose of most drugs are determined, at least in part, by various patient-specific factors. These factors can be, for example, patient's age. For most drugs, the dose you would give an adult patient is different than that you would give a pediatric patient. Again, because a lot of drugs are based off of weight or body surface area, pediatric patients obviously would get a smaller dose than adult patients. But even then, adults, as they get older, we talk about geriatric patients, typically 65 and older, sometimes they have to have their adult dose reduced back down because they lose a lot of body weight as you get older and their body changes, their functioning of their liver and kidneys change and such that we might need to give them a lower dose. So there's this whole spectrum of factors that go into determining the correct dose for a patient. And when I say correct dose, we keep talking about this usual dose. So, and you may notice this on your drug cards as you're learning the top 100 drugs. Most drugs have a range anywhere for something like 5 to 80 milligrams. Well, that seems like a really wide range. And so there's normally a usual dose or a starting dose. And that's kind of going back to this bell-shaped curve on this slide here. Just goes to show you that for most patients, there is an average dose or a starting dose that we know will produce the desired effect that we have for that drug in most people. But just going forward, you need to understand there are going to be some patients who are what we consider resistant patients or resistant individuals. Their body just doesn't react the same. Therefore, to get the response you want, you're going to have to give them a higher dose. If you don't, then they're going to be what we call subtherapeutic, or the drug will not be producing the benefit we had desired it to have. So resistant individuals oftentimes need higher doses. On the other hand, there's another, as you can see on the bell-shaped curve, a small minority, but still some patients who are, we don't know this ahead of time, but we find out they are considered sensitive patients. These are patients who respond much more exaggerated to a normal adult dose. But this exaggeration could make them kind of toxic or have adverse effects from what would in another person be considered a normal therapeutic dose. So those sensitive individuals would need a lower dose to be able to produce the effect without having too great of a response. And you're wondering, what makes these people different? Why are some people different than others? And there's always a host of reasons that can be involved. But oftentimes, it has to do with the way the body handles the drugs. And there's entire courses you're going to take on this called pharmacokinetics. And that will talk about how drugs are absorbed into the body, distributed in the body, and more importantly, I guess where I'm leading to is eliminated from the body. Because there we're talking about the functioning of two really important organs being the kidney and the liver have a huge role in removing drugs. And so the really complex interaction with all of those things can in some people lead to biologic variations, making them either resistant to normal doses of drugs or overly sensitive to a normal dose of drug. And therefore, while we will be calculating a lot of this on normal doses or average doses for patients, realize that there are going to always be individual variations. So going on to this slide, this is really important to help you kind of understand some terminology. And there's a lot of important terminology in this slide. And this slide, if we look on the figure, there's a lot of lines here. Let's just look at the curve. What is it? Well, let's describe it. On the x-axis on this curve is time. From time 0 to going out, and it could be in minutes and hours. There's not specified, but it's time. And it's time from the ingestion of a drug. And this is going to be an orally administered drug. What we see on the y-axis is the concentration. So clearly at 0, 0, but before we've actually administered, there is no drug concentration in the blood. But as soon as we swallow that pill, you'll notice the curve goes from 0, 0 on the axis, and it tends to slope upward, has a peak, and then slowly kind of fades away. Okay, that's to me, it looks kind of like a sand dune type shape, if you will. So that's what you have it. As you swallow a drug, it starts to dissolve in the stomach and become absorbed and get into the bloodstream. It tends to peak after all the drug has been absorbed from the stomach. Then it kind of peaks in the blood, and then it doesn't go any higher. And the reason it continues to go down is that the liver and the kidney start to remove it, and that's called the elimination. So where you see the dashed line that says time of peak concentration, to the left of that is what we call the absorption phase, because the concentration of the drug is still going up and up and up as we are absorbing all the drug into our system. After the time of peak concentration, you'll notice the concentration then tends to more slowly, but still eventually decrease over time, and that's the elimination phase. So drugs are absorbed up to a certain point, and then they're eliminated from the body. So let's talk about some important terms. The other dark lines on here, you'll notice it says maximum safe concentration and minimum effective concentration. Keep in mind, think about that. Do drugs that you take orally, think about something for a headache, maybe an ibuprofen tablet. As soon as you swallow that tablet, do you feel relief immediately? And the answer is no. Why? Because you need time for the drug to kind of be absorbed into your system so that you can then start to produce that effect. So when it starts to work is when there's enough of the drug absorbed that you're exceeding what's the minimum effective concentration for that drug. Now, keep in mind, these concentrations are going to be unique for every different drug, but for example, for ibuprofen, whatever its minimum effective concentration is, it takes as long as it takes for the body to absorb enough of the drug that you start to produce some of the symptom relief, like from a headache. Okay. And as soon as you start to get that relief, that doesn't mean it's done absorbing, but it will continue to absorb until all the drug is absorbed. What you don't want to do, for example, is to give a dose of a drug so that by the time it's all absorbed, that its peak concentration exceeds what we call the maximum safe concentration. If the level or the dose exceeds the maximum safe concentration, it should make sense that that's when you're going to start getting side effects. That's when you're going to have adverse reactions because there's too much drug in your blood, and that above a certain concentration is when you start to see those adverse effects. So a good dose of a drug should be the dose of a drug that puts the peak concentration well in between the minimum effective and the maximum safe. Meaning it's going to have enough to produce the effect that we want above the minimum, but still be less than, and hopefully well less than the maximum safe. And so as you can tell on the right-hand side where it says addresses safety, the term here is the difference between the minimum effective and the maximum safe concentration is called the therapeutic range. If the concentration of the drug is somewhere between the minimum and the maximum, then it's going to be in an effective range. You would like a drug to have as wide a therapeutic range as possible. That means the difference between having enough to produce your effect, that is above the minimum, should hopefully still be way less than the maximum safe concentration. So the larger that range, the safer it is to use that drug. You can produce the effects without a big risk of having side effects. Unfortunately, there are still some commonly used drugs that have what we call a narrow therapeutic index or therapeutic range. That is, the difference between the minimum effective and the maximum safe is relatively narrow, and those patients have to be dosed very carefully, or they could have problems because of the dose going too high. Anyway, so that addresses kind of what's on this graph that talks about addressing safety and getting the right dose. Some other terminology that's important to understand is kind of in the other dashed lines, I've alluded to it before, is the term onset. What is the onset of action? How long would it take for that drug to start to work? That's the time it takes for the drug to be absorbed to the level of the minimum effective concentration. So for ibuprofen, it might be anywhere from 15 to 30 minutes. That's how long it takes for most people to absorb that drug and get enough of it into the bloodstream that the concentration now touches that minimum effective concentration, right? Peak concentration has to do, obviously, when all of the absorption is done. So from there on out, there's only going to be continual elimination. That should make sense. And another important thing is duration. How long do drugs work? Drugs will produce their effect. Their duration of action will be from their time of onset, not from the time you first swallowed the capsule or tablet. Remember, it takes some time for it to even start to work. But the duration is from the time of onset, when it touches the minimum therapeutic concentration on the absorption phase, until it touches the minimum effective concentration on the elimination phase. Because after that time, then, as the drug continues to be removed from the body, you're no longer going to be able to produce its effect. So duration is from onset until the elimination concentration reaches the minimum effective concentration. So that's how long a drug will work. All right. And intensity is also not as commonly used term, but it really relates to the difference between the peak of your concentration of your drug to that of the minimum effective concentration. Clearly, the higher the peak relative to the minimum effective, the higher the intensity. So we would like to have a high intensity. We would like our drug to certainly work, but we have to be careful that our intensity is not so high that it starts to put the peak close to the maximum safe concentration, putting this at risk for adverse reactions. Okay, so all of this, the take-home message from this is to understand that dosing needs to be very precise. If we overdose, then we have too much drug in our blood, then we have adverse effects because we're exceeding the minimum concentration. If we underdose, then we will not get our therapeutic effect. So being able to do these calculations to ensure the right dose is clearly important for our drug action. So I think that's enough about that. Let's start looking at some dosing calculations. Okay. Now, as we said, we want the right dose, but what's interesting is that some medications can be effective for some reasons actually at low doses. And so one very common example of what we call low dose therapy is the use of aspirin. And the fact that you can use aspirin at much higher doses to relieve headaches and pain and muscle aches. But a very common use of it anymore is as a blood thinner to help prevent heart attacks by helping prevent clots from forming that could cause occlusion of a coronary artery vessel. So it turns out all you need is 81 milligrams of aspirin to accomplish the blood thinning, whereas, again, you need 325 to 650 milligrams to produce kind of the analgesic effect. So that's an example where there's no reason to use a higher dose and increase the risk of adverse reactions of using a 325 to 650 when you could accomplish what you need, which is the blood thinning effect at 81 milligrams. On the other hand, there are examples, especially, unfortunately, with chemotherapy. Those drugs have to try to kill and distinguish cancer cells from non-cancerous cells. And sometimes to be able to do that and to kill enough of those cells, you have to use relatively high-dose therapy to do that. Okay, so just some different examples there. But let's start with the first calculation here, where we would try to always use the minimum amount of drug that we can, the lower dose the possible, because the lower the dose, the lower the peak, the further away from the maximum safe concentration we would be. But we still have to be within the minimum therapeutic. So let's get as low to that minimum therapeutic as possible, especially in this question as it relates to Premarin, which is a conjugated estrogen taken by women to help treat often vasomotor symptoms that can occur with menopause, some very uncomfortable symptoms. So we want to alleviate those symptoms, but we also know, and we can't know who, but the more estrogen you use, the more in some patients you could stimulate possibly estrogen-dependent tumors or cancer. So we don't want to use too much estrogen and kind of potentially cause some increased risk for cancer, but we certainly want to give enough that we can reduce the vasomotor symptoms. So in this question, what it says is that a physician reduces a patient's daily dose of conjugated estrogen, or brand name is Premarin, from tablets containing 0.625 milligram to tablets containing only 0.45 milligrams. And the question asks, what is the total reduction in conjugated estrogens taken in milligrams during a 30-day month? So by reducing the dose, what total weight of estrogens will we be able to reduce, and therefore reduce the burden on the body from having to be exposed to? All right, so what do we know? We know the old strength at 0.625. We know the new strength at 0.45. And before we worry about the 1 month, let's just figure out how much did we lower the dose by. So let's take the old dose, 0.625 milligrams, and subtract the current dose, 0.45 milligrams, and see what we've done on a daily basis is reduce the dose by 0.175 milligrams every day. So every day we're taking that much less drug. Our dose is lowered by 0.175 milligrams. So to address the final answer to this question is let's figure out how much then we have actually reduced over a month's time. So let's start with our 30-day month. So we start with 30 days, and then we multiply it by the fact that we are reducing the dose by 0.175 milligrams per day. That's the daily amount reduction. So when we multiply that, you see the units of days cancel, and we would have a final result of 5.25 milligrams. So what that represents is that by the end of 1 month or 30 days, this patient will have taken 5.25 milligrams less estrogen than they had before. And that answers this question. So let's move on to another dosing issue, which is taking too much of a dose. We said, some drugs you need to do high dose therapy, but in other times the high doses are unintentional or accidental overdoses. And this happened in the past. It's not so much a current problem, but it's a good example of what can happen when the commercial product Tylenol, which is the brand name of acetaminophen. And acetaminophen is a very safe drug if used at the correct dose. The problem is, if you give too much of a dose, then you overwhelm the liver's capacity to metabolize the drug, to remove it, and you can get liver damage, and it can be fairly significant. So, and the reason this was happening is in our patients that are most sensitive or vulnerable to overdose are infants and small children, because again, an adult dose in them is going to be too much of a dose. So really at one point, there were actually 3 strengths of products for acetaminophen. There was what we called infant drops that had a concentration of 80 milligrams per every 0.8 mils, which is a funny number, but it essentially was the amount that was in these calibrated droppers. Okay, and that was intended for infants. But then when the infants got older and became children, say anywhere from 2 to 11 years of age, then they could take this liquid suspension. So it was essentially less concentrated because the older children can consume more fluid. They could have a larger volume. So now we were at 160 milligrams per 5 mLs, and that was the amount that they were supposed to take for themselves. But parents would often confuse those two and give essentially the wrong dose, would use the more concentrated drops for their children, and that could overdose the children. So let's look at an example of this. In this question, it says, over a 24-hour period, a babysitter and a blurry-eyed parent at night gave a young child 5 teaspoonful doses of acetaminophen infant drops, which have a concentration of 80 milligrams per 0.8 mLs by mistake, instead of the children's liquid, which has the concentration of 160 milligrams per 5 ml. And the question asks, how many milligrams of acetaminophen did the child receive, and how many times larger than the correct dose did they consume? Okay, so let's first calculate, based off of what the parent did, how many milligrams of acetaminophen did they administer to their child. So we'll start off by looking at this question, and it says that between the parents and the babysitter, over the day or the 24 hours, they gave a total of 5 doses. Okay, so we'll start with 5 doses. To figure out how much drug, we have to first convert dose to the volume of fluid or liquid given with each dose. So let's multiply 5 doses times the fact that each dose had a volume of 1 teaspoonful. Okay, so 5 doses times 1 teaspoonful per dose. Doses will cancel, and you should see that we have 5 teaspoonfuls. Now we need to convert from the units of teaspoonsful to that of milliliters. So this is just a typical conversion that we have to memorize in pharmacy, and that each teaspoonful, 1 teaspoonful is equivalent to 5 milliliters. So if we set it up with 5 milliliters on top over 1 teaspoonful on the bottom, you'll see that our units of teaspoons will cancel. And we will have then essentially multiplied 5 times 5 or gotten 25 milliliters. So in the one day, a child received 25 milliliters. But what we want to know, not the volume, how much drug. So what was the weight of drug the child received in that amount of time? Well, let's multiply that then by the concentration expressed as 80 milligrams over 0.8 milliliters. That way the units of milliliters will cancel and we'll get our final answer here. So if we do that, if we take 25 times 80 divided by 0.8 mLs, you would get a final value of 2,500 and your last remaining unit would be milligram. So 5 doses of this 80 milligram per 0.8 ml infant drops means that this child received 2,500 or 2,500 milligrams in that time. All right. So what's important to know is now we want to know how much of an overdose did they get, how many more milligrams than they should have gotten did they receive. So let's do the same calculation again, and I won't go quite as slowly, but let's do it with what they should have been given, which was the children's acetaminophen suspension, which has the concentration of 160 milligrams per 5 mLs. So again, they gave 5 doses, and each dose had 5 milliliters per teaspoonful, so 5 times 5 is 25. Now we're going to multiply that volume, though, by the new concentration, the one they should have received, which is 160 milligrams, and then divide that by 5 mils. Mils will cancel, and our final units, again, are in milligrams, and what we see is that what they should have received in that time is 800 milligrams. All right. So the last part of this question wanted to know how many times larger than the correct dose did they consume. So to calculate that, we simply take the amount that they did receive, which was the 2,500 milligrams, divided by what they should have received, which was 800 milligrams. And we see that this child in that 24-hour period received 3.125 times the amount of dose. Essentially, they had a threefold overdose in the amount of acetaminophen, which can cause certainly some health risks for the child. All right. Speaking of dangerous doses, a lot of times the problem comes in unintentionally giving the wrong strength product, like we talked about in the acetaminophen example for the pediatric. And this is not limited to just pediatrics. And a great example occurred with opioids. So hopefully you've heard about the opioid crisis and people becoming addicted to high-strength opioids such as oxycodone or hydrocodone, oxymorphone, things like that. Well, what was happening is we were getting a lot of overdoses with acetaminophen by people using these combination products of both opioid and acetaminophen. And we'll just use Vicodin or hydrocodone as an example. Let's talk about the Vicodin brand product. When Vicodin first came on the market, it came as a combination of 5 milligrams of hydrocodone along with 500 milligrams of acetaminophen. Okay, but then they came out with, as people were needing and wanting higher strengths of opioids or higher levels of pain relief, they started combining the hydrocodone with higher amounts of hydrocodone, but also with substantially higher amounts of acetaminophen. So the Vicodin ES product contained 7.5 milligrams of hydrocodone, but it had a whopping 750 milligrams of acetaminophen. Okay. Then they came out with even a higher strength potency, a high potency Vicodin that had 10 milligrams of hydrocodone, and then again a large dose of 660 milligrams of acetaminophen. And again, while they were driving the opioid demand or the desire for the hydrocodone increased their usage, they were getting so much extra acetaminophen that despite their pain relief, they were overwhelming their liver's ability to metabolize that amount of acetaminophen, and they was getting to have a lot of liver failure, liver damage, not from the opioid part to it, but from all that extra acetaminophen. Okay, so they knew this was happening. So by 2011, they came out to the manufacturers and said, hey, we don't need all this extra acetaminophen. Some acetaminophen is synergistic or works well with the hydrocodone, but it shouldn't be directly proportional to the amount of hydrocodone. So now all hydrocodone containing products that contain also have acetaminophen with them have a standardized 300 milligrams so that you're not going to be getting as much of an overdose with all that acetaminophen. So that was a big improvement. And we also talked about how, with the example on the previous page about the pediatric between the infant drops and the pediatric or the child suspension, to avoid that problem, Johnson & Johnson, the makers of Tylenol, essentially discontinued those infant drops. And so the only thing really available is the pediatric suspension, the children's suspension, to help minimize this sort of pediatric overdose. All right. So we've been talking about dosing and how important getting the right dose is so that we don't become toxic and overdose somebody. Well, another issue about dosing that just gets brought up is, can you take a tablet and break it in half? Would it have essentially half the drug that the whole tablet has? And you'd obviously think so. And some tablets are scored. And again, a picture here on the left-hand side, you can see a non-scored tablet is one that just looks like a normal tablet. A scored tablet is one that has a line or a groove that's been kind of etched in the tablet. This groove should make it easier to be able to split in half so that you could take half a tablet. Why would you need to do that? Well, there's a couple of reasons. One be the fact that we said that's, if a drug is not available in a certain strength, and you want half of that strength, then it would allow you to use, for example, a 5 milligram tablet, split it in half, and you can give 2 doses of 2.5 milligrams. That might be important for a pediatric patient who needs a lower dose, or as we talked about before, sensitive patients who over-respond to, for whatever reason, to a drug that they need a lower dose than is even commercially available, then splitting a tablet can happen. But oftentimes what's been motivating a lot of patients to want to do this is the pricing in the U.S. for drugs, in the fact that it is sometimes cheaper to buy a 10 milligram tablet, split it into 2 and have 2 5 milligram halves than taking and purchasing the 5 milligram strength, because the 10 milligrams are not twice as expensive as the 5 milligrams. So you could save money by doing the splitting. And so this has been something pharmacists have struggled with a while. We want to help our patients maximize and their money and get the cheapest drug therapy available. At the same time, the question really kind of says, how much money can be saved, and is it really safe to do this? So let's start with this aspect about how much money could we save by doing this tablet cutting thing. So let's start with this. It says, a patient cuts a 100 milligram scored tablet to take his 50 milligram daily dose. A prescription for 30 50 milligram tablets costs $40, and a prescription for 30 100 milligram tablets costs $45. The patient asks the pharmacist to weigh an uncut tablet in 2 halves. The uncut tablet weighs 240 milligrams, and the cut halves weigh 125 milligrams and 115 milligrams, respectively. So they didn't split exactly in half. Question is, how much money did the patient save per month by cutting these tablets? And then on the opposite, and that's the good side, on the bad side, what was the percentage error in the weight of the cut tablets compared with the exact halves? This percentage error would kind of reflect essentially the amount of dosing error that was occurring kind of on a daily basis by having this unevenly split tablet. So let's start with the calculating the cost. And the first thing we need to do is convert from tablets into doses. Okay? Because we know he bought 30 tablets. However, and they were 50 milligrams. So let's start with this. Bear with me. 30 tablets times the tablets he bought here are 50 milligram tablets. So 30 tablets times 50 milligrams per tablet would give us the number of total milligrams. We're in milligrams. Now what we can do is times it by the relation that we know that for this patient, every 1 dose has 50 milligrams. So if we times 1 dose over 50 milligrams, you see that milligrams will cancel, and this should be pretty obvious. If you've got 30 50 milligram tablets and you need 50 milligrams for every dose, you're going to get 30 doses. All right, let's go ahead and then calculate the cost of that. Well, we paid $40 for the prescription that contained 30 doses. So $40 divided by 30 doses means we were essentially paying $1.33 per dose. Okay? Now that's easy breezy. Hopefully that made sense. Now, what's a little bit weirder is now let's look at this other example where let's actually buy 30 100 milligram tablets. So what's different here is we start with our 30 tablets again, but now we're going to multiply by the fact that there's 100 milligrams per tablet. So 30 times 100 milligrams per tablet would give us essentially 3,000 milligrams. Now we're still going to multiply by the fact that our dose is still only 50 milligrams. So we're going to multiply by the fact that for every one dose, we need 50 milligrams. So now our 3,000 milligrams divided by 50 milligrams means we're getting 60 doses from this prescription of 30 100 milligram tablets. All right. Do the same thing to calculate the cost. We paid $45 essentially for the 100 milligram tablets. Now we're going to divide it by 60 doses. We can see that our cost per dose has decreased to 0.75 or 75 cents per dose. Okay, so not quite, but almost half of what we were to pay with initially. To answer the question, though, let's go back. It says, how much money did the patient save per month by cutting these tablets? All right. So the amount saved is going to be calculated by calculating the difference between those two. So what we're going to do is take the 30 doses that we paid for each month and multiply it by the cost savings, which is to take what we were paying, the $1.33, and subtract it by the 0.75, which we're still paying. The difference between those is the amount we save per dose times 30, means that in that 1 month time, we essentially saved $17.40. Okay? Again, this was pretty straightforward math, but it's setting it up, and you've got to do one thing at a time. First, how much did we pay for the 50 milligram tablets, and how much money is it per dose? How much are we paying for the 100 milligram tablets per dose? Not per tablet, but per dose. And then finding the difference between those two. The second part of this question, though, was about the percentage error. What was the percent error in the weight of the tablets cut compared to exact halves? Okay, to calculate that, we need to use our percent error formula. And this is an important one just to kind of learn. In this case, we're going to take the actual number that we have, whatever the actual experimental thing that we determined is, subtract it from the expected, what we expected to occur, and divide it by the expected. Okay? And then to convert it to a percent, we're going to multiply by essentially 100. All right? So to turn those into actual numbers, what do we mean by expected? This is an important part, obviously, to that percent error formula. What did we expect? We expected essentially this medication to have a total weight of 240 milligrams. One tablet weighed 240 milligrams. If you split that into two halves, essentially if you divide it in half, then each half should have weighed exactly 120 milligrams because one tablet weighed 240. Split it into half, each half should weigh 120. But that's not what we actually saw. So what we will do is calculate the error. And you can use either, let's do it for either half. So the first half, we measured at 125 milligrams. So we would take our actual of 125 milligrams, subtract our expected, which we said was 120, and then divide by our expected, which was 120. So essentially 125 minus 120 is 5. 5 divided by 120 times 100 gives us 4.2%. Okay, so, and this would be essentially a positive value. The error you can see essentially is going to be 4.2% over what we expected. Whereas if you do the same calculation on the second half, which was a little bit less, you would take your 115 milligrams, subtract 120, divide that by 120, do that math, and you get the same number you get, but it's negative because it was less than what we predicted. So the percent error is still the same, but in the one, it was 4.2% over the dose, and the other one, it was 4.2% less than the dose we wanted. Okay, so, and this is not unexpected. So I just included this because it's an interesting issue you're going to have to deal with in practice because patients oftentimes want to be able to save money by splitting their tablets. And sometimes insurance companies in the past have even encouraged that because then the cost of the insurance companies is less. But I got this figure from an interesting study that basically kind of showed this. It said that hand splitting of tablets can result in inaccurate doses and may present clinical safety issues, especially for drugs that have this narrow therapeutic window in which large fluctuations of the drug concentration are a problem. As I mentioned before, when you have a narrow therapeutic window, the difference between the minimum therapeutic and the maximum safe is relatively narrow. So if every time you're taking a tablet, the actual peak concentration is going to sometimes maybe be above it or below it, then you're not going to get the desired response. And you can see that in the figure here is that the green line shows the same sort of absorption and concentration, okay, of the drug that occurred in the system over time, and the green line represents a whole tablet. So that's what we would want to be able to mimic. Can we get as close to the green line as possible when we split our tablets? And what you can see is that essentially, and I'll show you a picture on tap, the tablets don't always split evenly, and it results in one dose being above the green line and the second dose being conversely below the green line. And while for some drugs that have a wide therapeutic index, maybe that's just fine and completely safe, and therefore the financial benefits are worth it. Whereas some other drugs, you really as a pharmacist need to recommend patients and consult with prescribers that would not be a good idea, because there is this variation that occurs when you split tablets, and that could lead to some dosing issues. And that's the take-home message from that slide. All right, let's keep going with some dosing now about pediatrics. So some things to know about pediatrics is they're not just little adults, meaning it isn't just that they have less mass, less bone weight and muscle weight and fat weight, but their bodies are still developing, and therefore their liver and their kidney and other systems aren't completely as functioning as they will be as an adult. Therefore, you need to be more careful, and it isn't just always reducing a proportional amount based off of weight. And that's why, as the second bullet point says, dosage should be age of patient either on body weight or alternatively things like body surface area. And we'll calculate body surface area here later in these sections on dosing. But just realize that while we do some drugs on weight for children, sometimes it isn't just weight. It has to use other things to account for the fact that their organs don't function in quite as well either. Okay, let's start with the question. It says, a 25-year-old child is to receive 4 milligrams of phenytoin per kilogram daily as an anticonvulsant. How many milliliters of a pediatric phenytoin suspension containing 30 milligrams per 5 mLs should the child receive? Okay. This is a very classic dosing situation. And most importantly, I'll put the answer up here in a minute, but this is really about unit conversion. You have to start with where you need to start with and then convert from one unit to the next unit to the next unit. So what do we know? We know the weight of the child, and the child's weight is in pounds. We know the amount, the dosing of the drug is a certain weight of drug per weight of child, but that weight is in kilograms. So already you can see we're going to have to go from pounds to kilograms to use the dose. When we're there, we'll have the amount of drug we need in weight of drug, but what we need to calculate is the volume of the liquid to give. So there we'll have to use our concentration. So it helps me if you kind of start to think of the roadmap of where do I need to start with? I'm going to start with the weight of the child, figure out the weight of the drug, and then figure out the volume of the final commercial product. That's the order we're going to go in. And then set up our math first. Don't solve anything on your calculator until you've set it all up, you've canceled all your units, and you can visually inspect that by doing the math you're going to do, you will end up with the correct unit. So let's start with 25 pounds. That's the weight of the child. Times our first conversion, the fact that there is 1 kilogram in every 2.2 pounds. Pounds will cancel when we multiply, and we will be in the units of kilograms. Next, we multiply by the fact that we want 4 milligrams per kilogram. By doing that, the units of kilogram cancel, and we're now in milligrams of drug. The last step is to multiply by the concentration in the form of every 5 milliliters on top has 30 milligrams on the bottom. And we express the concentration this way so that the units of milligrams cancel. And if you go across and cancel all your units, the last remaining units is in milliliter. Okay, so if you take now we can do the math. 25 times 1 divided by 2.2 times 4 times 5 divided by 30. Just work the math straight across, and your final number, if you do the math correctly, should be 7.6. And since the units are milliliters, we've calculated that this child would need 7.6 milliliters per day as the volume to be able to provide the correct dose of 4 milligrams per kilogram per day of phenytoin for this 25-pound child. And that's the answer to that question. All right. As we said, though, there are some drugs, and it isn't just pediatrics, and we'll get to here, especially in cancer patients as well, where the body weight, where drugs don't just go into muscle and tissues. If they don't just go in the different parts of the body, then using the weight to calculate how much drug to give would give too much drug, because if it's not going to go into the muscle tissue, then using somebody's body weight, which has a large component of it to be muscle, then you will overestimate the drug that they need. So what's not important is that you would know, you can't just know by looking at the drug if that's the way it's dosed, but understand when you do look up the dosing for certain drugs, that certain drugs, because they might be that kind of drug, should not be dosed based off of body weight, but instead are often based off what they call on body surface area, which takes into account not just weight, but their physical height. Okay, so a good example of this is, picture somebody who weighs 180 pounds. Can you really picture that? Or does it matter? I mean, if I told you this person who weighs 180 pounds stands 5 foot 2 inches tall, does that person looks different than I say somebody who weighs 180 pounds that stands 6 foot 4 inches tall? Well, that's a huge physical height difference. You know, the short person at 180 is probably going to be kind of obese given that weight for that height. Whereas 180 pounds for somebody who's 6 foot 4 is not much weight at all for somebody who's that tall. So it's a way to describe somebody's body by corresponding both the weight to the height. And for some drugs, that is the most appropriate way to determine how much drug they need. So, and there are multiple ways of calculating this body surface area, this relation between height and weight together. What we're going to use in this course is the most common formula. It's probably the easiest one to memorize to some extent. It is called the Mosteller formula. So we will always be using the Mosteller formula, so I may not always call it the Mosteller formula. If I just say the body surface area formula, this is the particular formula we're going to standardize to use. And it's pretty straightforward, other than the fact that you got to know where your square root is on your calculator. So remember, to calculate body surface area, this is very important as well, you need the units of height in centimeters multiplied by the patient's weight in kilograms. Take height in centimeters times the weight in kilograms, divide that by 3,600. I don't know where that number comes from. It's just part of the formula. Divide it by 3,600. Then remember to take the square root. So remember, height in centimeters times the weight in kilograms divided by 3,600. The square root of that gives you your final answer. And those units, when you do all of that, start with centimeters and put in kilograms. And when all that magic happens, your final number has the units of meters squared. All right? So let's practice this. So it says, question, a treatment regimen for breast cancer requires paclitaxel 175 milligrams per meter squared to be given intravenously every 3 weeks. How many milligrams of paclitaxel should be given to a patient who stands 5 feet 3 inches in height and weighs 87 pounds? And we're going to use the Mosteller formula to calculate the body surface area and then apply it to the dosing schedule. All right? So there's a lot of prep work. The only concern I have for you guys doing this whole body surface area formula is making sure you take the time to correctly get your height in centimeters and your weight in kilograms, though you have to have those values to be able to use the formula. And oftentimes we don't give you the patient information in those units, so you have to be able to calculate that. So let's make sure you can convert height into centimeters, because usually it's given to you in feet and inches. So what I always do is I start with the fact that I know there are 12 inches per foot. I can remember that. So let's take this patient's height, which was 5 foot 3 inches. Ignore the 3 inches for now. Let's just start with the 5 feet. Let's take 5 feet times 12 inches per foot. So my units of feet cancel. So 5 times 12 is 60, and my units are inches. So the 5 feet of my height means I have 60 inches. but I was 5'3", or this patient is 5'3", so we'll take the 60 inches plus the 3 additional inches, meaning this patient's total height in inches was 63. Now we can convert that height into centimeters. So I'm going to take my 63 inches times the fact, and this is just a very useful conversion you need to start to memorize, is that there are 2.54 centimeters per inch. So when I multiply by that, my units of inches cancel, and so 63 times 2.54 gives me a total height of 160 centimeters. All right, step one, I converted their height from feet and inches to centimeters. Yay. Now I got to convert the weight. Luckily, that's a little bit easier. But remember, the weight we were given was in pounds, and we have to determine it in kilograms. So start with 87 pounds times the conversion, which is on top. 1 kilogram has over 2.2 pounds. So by lining it up that way, pounds cancel my units. So 87 divided by 2.2 gives me 39.5 kilograms. I now know their height in centimeters, 160, and their weight in kilograms, 39.5. So now I'm ready to fill in the body surface area formula. So I've written it as the square root of, and then you can see 160 centimeters times 39.5 kilograms divided by 3,600. And again, if you do all of that, including the square root, you'll see that the value is 1.32. And remember, the units using this formula are metered squared. That is this patient's body surface area. We haven't calculated the dose yet. All we know is what their body surface area is, so that our last step can be to calculate the dose, which is relatively straightforward. So we take this patient's body surface area, which is 1.32 meters squared, times the dosing of 175 milligrams per meter squared, and you see the units of meters squares cancel, and 1.32 times 175 gives you 231 milligrams. And that's the correct answer for this. My last thing that I will try to say here is the fact that you'll notice that the units of body surface area in meters squared give you numbers that are much smaller than actual weights in kilograms. So for example, this person's body surface area was 1.32, whereas their body weight was 39.5. When pharmacists and prescribers have made mistakes, like an example here, instead of doing 175 milligrams per meter squared like it should have been, if you treated that like 175 milligrams per kilogram, then you would have multiplied the 175 times 39.5 instead of the 1.32. You would have gotten a much larger number. And unfortunately, those overdoses often involve chemotherapy type drugs, which are particularly toxic and have been invariably fatal. So the important message here is, while many drugs are based off of weight and therefore multiplying by kilograms is normally acceptable, you must take the time to make sure that it is correct for that specific drug, because there are drugs like this example for paclitaxel where it's dosed off of body surface area, not body weight. So just be careful with that. All right, let's keep practicing that, because this is important. And what we're going to do is add to it. We're going to do a very similar type of calculation as we just did with the body surface area using the Mosteller formula. And then we're going to kind of compare it using a different way, not commonly done, but there are body surface area nomograms, which are kind of these little figures you can use to figure out the body surface area instead of calculating it. So let's just go through this example. And it says, if a daily dose of a drug is given in the literature as 8 milligrams per kilogram of body weight, or 350 milligrams per meter square, calculate the dose on each basis for a patient who weighs 150 pounds and measures 5 feet 8 inches in height. Okay, so we want to know the dose based off of the body weight. We want to know the dose based off of the body surface area, and then we'll compare that from the formula to the nomogram. So let's just do it. I'll go through these a little bit quickly. They work just like the one that we just did. So first step is height, and we'll go from feet and inches into centimeters. So take 5 feet times 12 inches per foot, we get 60 inches. Add the additional 8 inches means we have 68 inches in height. Take 68 inches times 2.54 centimeters per inch, and you get 173 centimeters. Next, do the weight conversion. 150 pounds times in every 1 kilogram, there are 2.2 pounds. Therefore, our weight in kilograms is 150 divided by 2.2, or 68.2 kilograms. Now that we have those values, we can put them into our Mosteller formula and take 173 centimeters times 68.2 kilograms, divide that by 3,600, and take the square root of that to get a value of 1.81 meters squared. I went through that kind of quickly. Hopefully you can follow that math. Same thing as we've done before. So the last step is to do first letter A, which was to calculate the dose on body weight. Okay, so remember to be careful here. The body weight was 68.2 kilograms times, now this is what's important, the correct dose based off of weight was 8 milligrams per kilogram. So we take 68.2 times 8, units of kilogram cancel, and we see that dose would be 546 milligrams. Now let's base the dose off of body surface area. Take the calculated body surface area of 1.81 meters squared times the correct dosing schedule for the body surface area, which was 350 milligrams per meter squared cancel. So therefore 1.81 times 350 gives you 638 milligrams. All right. So those, you can see they're close, but not exactly the same. But those are the two different ways for this drug you can calculate the dose this patient needs. Now, letter C says, okay, let's use a body surface area nomogram. And you can see that nomogram here. And what you see on the left-hand side is a scale for height. And what makes these nomograms a little confusing is that each scale for height and weight has two sets of units. So on the height, if we just look on the left-hand side for height, you can see on the left-hand side of the scale, we have numbers given in the units of centimeters. And on the right-hand side of that same scale for height, we have it in inches. All right. Look on the far right, we can see a similar scale for weight, where on the left of that scale we have kilograms and on the right we have pounds. So the first thing that you're going to want to do is draw a circle corresponding to the patient's height. And we said this patient has 173 centimeters in height. So I put my circle right about where I think 173 would be on the left-hand side of the height scale. All right. The next step is to find their weight on the right-hand scale. And we said this patient was 68.2 kilograms. So you can see I drew my circle kind of close to where the 68.2 would be. The next step to doing a nomogram is to use a ruler to connect those two dots. So you line your ruler up and you draw a line from the height down to the weight that intersects both of those values. And to calculate the body surface area, you look to see where it intersects on that middle scale. So if I draw that circle right where the red line crosses over the body surface area scale, you can see it's right about at the 1.8 location on that nomogram. Okay, so that's pretty straightforward, although you still have to calculate your units of body weight and height in the correct units. But instead of having to use the Mosteller formula, you can draw this line across there, and wherever it hits the body surface area scale, you can determine that to be their body surface area. So if we just finish off this question using the nomogram, we would take our value from the nomogram of 1.8 meters squared times our 350 milligrams per meter squared and see that the dose would be 630 milligrams. And if you compare that back to our previous, the value of like 634, you'll see that it's essentially very close to what we had. So either way works and is another way of just being able to calculate the dose. All right, we're getting close to the end here. Let's do a couple of last ones that kind of relate to combinations of drugs. So let's see. The question says, an oncolytic agent, lapatinib, or brand name is Tykerb, is administered in the treatment of breast cancer at daily doses of 1,250 milligrams for 21 consecutive days. Okay. And this is in combination with another drug, Xeloda, which is administered in a dose of 1,000 milligrams per meter squared per day during the first 2 weeks, or days 1 to 14, of the 21-day treatment cycle. Calculate the total quantity of each drug to be administered during the treatment cycle for a 5'2" tall woman who weighs 110 pounds, and use the Mosteller formula to calculate the body surface area. So this is a good example of the kind of complicated regimens that you'll see when you try to calculate doses for patients doing certain sorts of chemotherapy. So the one thing I thought I would just kind of, I included this little figure here. You don't need it for on the top right for the math, but just to understand. So the drug, the chemolytic drug, the drug that's going to kill the cancer is the Tykerb. Okay. But by combining it with the Xeloda, which you can see here on the graph, is the kind of, by using the Xeloda by itself, you will get a cumulative progression of free of survival. That is, the further to the right the line is, the longer the number of weeks, the greater the survival is. So by combining the two agents together, you can see that we increase the number of patients that survive for a longer period of time. So these two drugs work better in combination than they do alone. Okay, and that's kind of, you'll see, which makes a lot of drug therapy, and especially for chemotherapy, confusing, because there are various combinations of drugs, not just one, and they're used for different, in this case, their dosing is based off of different routes, and they're given for different time frames within the treatment cycle. Lots of confusion, probably worse than my explanation here, so let's just keep going. So to answer this question, we want to determine the doses of the drugs. We know that the Xeloda is dosed off of metered squared, or body surface area, so let's start by calculating this patient's body surface area. And we'll do that by starting with their height of 5 feet. They're 5 foot 2 inches, so we'll start with 5 feet times 12 inches per foot gives us 60 inches, plus 2 inches gives us 62 inches. 62 inches times 2.54 centimeters per inch gives us 157 centimeters. We have their height in centimeters. Their weight was 110 pounds. Divide that by 2.2, units of pounds cancel. We see that this patient weighs 50 kilograms. Now we can calculate the body surface area. We'll do that by 157 centimeters times 50 kilograms divided by 3,600 and the square root. We get a body surface area of 1.48 meters squared. Okay. Now we can calculate the dose for the Tykerb as simply by taking, that one was just dosed as 1,200 milligrams a day. It's not per kilogram. It's not per meter squared. It's just 1,250 milligrams per day. So the total cycle dose is, to start with the fact that we said a treatment cycle lasts for 21 days. So 21 days times the 1,250 milligrams per day would give us the total weight in milligrams. But what we'll want to do is convert that to grams, since that's just a larger number. So let's go ahead and take our weight in milligrams times the fact that in every 1 gram, there's 1,000 milligrams. Units of milligrams cancel. So by taking that number and essentially dividing by 1,000, we see that the total cycle dose of the Tykerb is the 26.25 grams. Now we can calculate the dose for Xeloda. We know that a single daily dose will be based off of their body surface area. So we would take the 1.48 meters squared, which is their body surface area, times the fact that they're getting 1,000 milligrams per meter squared per day. Units of meters square cancel, and we would have a total of 1,480 milligrams per day. So now we go back to the total cycle dose, and remember, this is what's a little bit different. It said the Xeloda is only given on days 1 to 14 of the treatment cycle. So we have a total of 14 days. So we take 14 days times the 1,480 milligrams per day, and we're in milligrams now. Convert that to grams by multiplying by 1 gram per every 1,000 milligrams. Milligrams cancel. We get units of grams. And our final answer here would be 20.72 grams of the Xeloda. And that's how you would answer that question. All right. All right. So let's do another question here, keeping up with our body surface area and chemotherapy type drugs. So we'll start with a patient weighs 165 pounds and stands 5 feet 6 inches tall. This patient is to receive a dose of a drug of 250 micrograms per meter squared per day of the sargramostem by IV infusion over a 4-hour period. What dose is this patient receiving in the units of micrograms per hour during the infusion? Okay. And I give options here because, again, just so you can kind of practice what it would be like to do these kinds of calculations with a multiple choice test, but let's just drive on and answer this question. All right. So there's a lot of information here. Where do you start? What do we need to know? Well, let's go back. In the end, we need a value for this patient that is in the units of micrograms per hour. So let's keep that in mind. So what do we know? Well, we know their height and we know their weight, we could use that to come up with body surface area, because we know the dosing is in micrograms per meter squared. So if we multiply the body surface area in meters squared, we would just be in micrograms per day. Then remember, this infusion is going to be over 4 hours. So then that's where we can get our units of hours. So just trying to come up with a scheme here, we're going to have to go to body surface area, and body surface area will be able to calculate the dose. And then from the dose, we can get the infusion by using the 4-hour infusion period. So that's kind of the roadmap we're going to follow. So let's quickly, again, calculate the body surface area by starting with their height, and would take 5 feet times 12 inches is 60, plus their additional 6 inches gives us 66 inches. 66 inches times 2.54 centimeters per inch gives us 168 centimeters. The 165 pounds divided by 2.2 gives us 75 kilograms. Put that into the formula of 168 centimeters times 75 kilograms divided by 3,600 and take the square root. We get 1.87 meters squared. Now we can calculate the total daily dose. Well, the total daily dose is going to be the 1.87 meters squared times the 250 micrograms per meter squared. So meters squared cancel. And we can see that in a day, they're going to need 468 micrograms. But that total daily dose isn't going to be administered over the whole day. We want to administer that daily dose over what amount of time? We said to infuse that daily dose in 4 hours. Okay, so it's pretty straightforward. Essentially, you're going to take the 468 micrograms divided by 4 hours, and you get the total value of 117 micrograms per hour. And that would be the final answer to this question. Okay, so this kind of shows you, going back to our multiple choice, the correct answer was 117 micrograms per hour was letter B. And I won't go through all the different variations, but you can see there are lots of ways you could make mistakes on this. And this goes examples of using, instead of dividing by 2.2 to go from pounds to kilograms, you could multiply by 2.2. That would be bad, because look, instead of dividing by 2.2, you essentially get a twofold overdose, because your expressing weight in kilograms is too high. All right. And you could also then underdose somebody by doing the wrong conversion from going in the height from inches to centimeter as calculating the body surface area. And again, letter D shows you what could happen if you don't take the square root. That's a really bad thing as well, because then if failing to take the square root during the body surface area calculation, your value is way too high. And look at it, you could cause a twofold overdose by doing that. Okay. And then lastly, super overdose is by giving the total daily dose and saying that's the amount per hour, instead of taking it but dividing it by the total daily dose divided by 4 for the 4 hours and getting the correct answer. You could get a fourfold overdose. So there are lots of definite ways you can make mistakes in these calculations that could lead to potential overdoses to patients, which is why we spend so much time on trying to perfect this skill in terms of correctly calculating a patient's dose. So with that, I'll close out this lecture.